Hello again, everybody. Welcome to case study number 16. This is going to be an adult with altered mental status, and I do plan on doing some more vignettes with altered mental status because there are so many different causes. So I'm calling this Altered Mental Status in an Adult Part 1. All right. If you haven't had the opportunity yet, please consider subscribing to my Patreon. I've got the link below in the description of the video, or you can click on the I button on the upper right-hand corner. I really appreciate all the contributions I can get to help offset the cost of these videos. And I thank everybody who has already contributed and those of you for your consideration. All right, we got a 32-year-old white man presenting to the ED via EMS after he was found unconscious by his wife in the garage. She elaborates that there was no running car. It's always important to know if someone's in a garage. His wife says that he was in his normal state of health this morning when she left for work. He's currently conscious but is somnolent and confused. GCS is 12 out of 15. He was recently laid off from his job. His wife says that he occasionally binge drinks when stressed. He doesn't smoke or do recreational drugs to her knowledge. His past medical history is significant for major depressive disorder, which has been controlled, and chronic back pain from an injury he sustained in the military. His medications include paroxetine and hydrocodone. And his vitals are as follow: blood pressure 115/72, heart rate 121, that's high, respirations 22, that's high, temperature 97.2, satting 99% on room air. All right, what do we want to do for physical exam? First of all, is this patient stable? He appears so. All right, so his physical exam, he's obtended and stuporous. HENT shows he's normocephalic, that's important, possible head injury. No evidence of injury. Pupils are equally reactive and to light and accommodation. No apparent pain on neck flexion. Chest and lungs clear to auscultation. Heart is tachycardic, no murmurs. Abdomen soft, non-tender, non-distended. Liver and spleen not palpable. Neuro and psychiatric examination show altered mental status and no focal signs. Super important, because the big thing we got to rule out when a patient comes in with altered mental status is, of course, a stroke. This guy's really young, so it's almost certain that he's not having a stroke, but it is something that we always want to rule out. All right, so what is our differential? Well, we got a patient with altered mental status and a non-focal exam, meaning no focal neurologic signs. So the mnemonic for altered mental status with a non-focal exam is DIM, D-I-M. So D stands for drugs. That can be drugs of abuse. It can be alcohols, not just alcohol, but alcohols, and prescription drugs, particularly opiates can do it. Infections, particularly pneumonia, meningoencephalitis, younger person, and urosepsis. Metabolic, all sorts of them. Blood glucose, thyroid issues, any possible type of electrolyte derangement, sodium, potassium, and then, of course, renal failure. Uremia can cause altered mental status. This is not a comprehensive list. So if you want a comprehensive list, here you go. I found this online. You can print this out if you want, but we're not going to go into all this. So our initial workup. So the first thing that we want to do, because there's always a possibility of alcohol and a possibility, given the fact that he's on painkillers, we want to make sure that we're giving him fluids, and because you're giving him fluids, you have to give him thiamine because he does have a history of binge drinking. We want to give him sugar because hypoglycemia is a serious cause of altered mental status. And of course, we want to give him naloxone because of the fact that he has got altered mental status, but also because he is prescribed opiates. Now, you can do the finger stick glucose or not do it. If you're giving him dextrose right away, you don't really need to worry about it. But it is something that typically is done by EMS, so it's important to take that into consideration. So we're going to get arterial blood gases, metabolic acidosis, common cause of altered mental status. We're going to get electrolytes. We're going to get a CBC, possibility of infection. We're going to get a chest x-ray, look for pneumonia. We're going to get an EKG, just because of electrolyte derangements can cause cardiac issues. We're going to get a urinalysis, looking for infection, looking for crystals, looking for red blood cells. We're going to get a urine drug screen and a blood alcohol. Always going to get that when you got altered mental status. And then we'll get a plasma osmolarity. So what do we find? I highlighted everything in red that's abnormal. So you will be given these labs, normal values on your exam. So what do we see? Well, the arterial blood gas is low. So we know he's got an acidosis. Now you need to know what kind of acidosis. So what you're going to do is you're going to look at your PCO2 and you're going to look at your bicarb. PCO2 is low and the bicarb is low. Which of those would give you acidosis? A low bicarb. So we know this is a metabolic acidosis. Now we also see that his creatinine is 2.2, meaning that he's got acute kidney injury. Okay, CBC within normal limits, chest x-ray unremarkable, EKG shows sinus tach, not a surprise. His urinalysis shows positive red blood cells and unidentifiable crystals. So we know there's something going on with the kidneys. Urine drug screen and BAC shows positive cannabinoids and a blood alcohol of 0, and the plasma osmolarity is 316. All right. These are some formulas you should know for metabolic acidosis. I am not going to go into these. I do go into them in my renal lectures, so you can go back and watch those if you want. These are things that you should know. What I do want to point out is the osmolar gap. A lot of people don't know this. If there is an osmolar gap, then the number one cause is an alcohol. So alcohol intoxication, ethanol intoxication, ethylene glycol, methanol, and so forth. So we know that this patient has an anion gap metabolic acidosis. You can go back and use this formula and figure out that he's got an anion gap. So I'm not going to go into that. So an anion gap metabolic acidosis, you use the mnemonic MUDPILES. M for methanol toxicity, U for uremia, D for DKA, and other ketoacidoses, including alcoholic ketoacidosis, P for paracetamol, also known as acetaminophen or Tylenol, I for isoniazid, iron is another possible cause, L for lactic acidosis, E for ethylene glycol and ethanol toxicities, and S for salicylate toxicity. Okay, so what we know, if you go back and you use that formula, you know that he has got a high osmolar gap. So what that means is that this is probably an alcohol. Now his BAC is 0, so we know it's not ethanol, and he's got stones in the kidneys. Okay, what does that mean? That means that it's likely ethylene glycol, and he's got a secondary acute kidney injury given that creatinine. What do we do for treatment? Aggressive fluids, clean out those kidneys, and famepizole. Famepizole will reduce the amount of ethylene glycol that gets converted into toxic substrates or products rather, and that will mitigate further damage. Now, if you don't have famepizole on hand, you can give them a shot of vodka. It'll competitively inhibit the alcohol dehydrogenase, if you remember your biochem. All right, so the further workup is going to be to confirm with serum ethylene glycol. He's going to be admitted to the ICU. Maintenance fluids, pulse ox, monitoring, insert Foley, check Isonos. That's your typical ICU labs. We're going to consult toxicology. We're going to consult nephrology because remember, metabolic acidosis is one of the indications for dialysis. And then we'll probably also want to consult psych because this appears to be a suicide attempt. Now, alcohol poisoning, you suspect in any patient with AMS and an osmolar gap. There are a lot of different types of alcohol poisoning. Now, one of them that's fairly frequent, usually in teenagers, is isopropyl alcohol toxicity. And when I say common, it's not really common, but it's common on boards. So that, unlike the others, are not going to disturb your acid-base status. What you will have, though, is the osmolar gap and ketonuria. So ketonuria typically happens within the context of a metabolic acidosis. But if you have ketonuria and a normal acid-base status, that points to isopropyl alcohol poisoning. The treatment here is fluids, gastric lavage, and dialysis. Now, methanol is toxic to the eyes. So the patient may have altered mental status, but if they are able to communicate with you, they may be able to confirm that their vision is off. The treatment here is identical to ethylene glycol, just like we did here, fluids, fomepizole, and dialysis. With ethylene glycol poisoning, they're going to have the altered mental status and slurred speech. They're going to come in looking like they're drunk. However, unlike a drunk person, they're not going to have an elevated BAC. What they will have is acute kidney injury and crystalluria. The treatment here is the same, fluids, fomepizole, and dialysis. With ethanol poisoning, you know what this looks like. Drunk person. They got alcohol on the breath, slurred speech. They can be altered if they've got a high enough BAC, but the BAC is going to give it away. And the treatment here is going to be fluids, dextrose, and thiamine. You always need to give thiamine. When you got a drunk patient, you're going to give them fluids. So to recap, make sure you tend to your ABCs first, make sure the patient's stable, then determine whether there are focal signs. If there are focal signs, think of something neurologic, obviously, like a stroke or a seizure. Determining the cause of altered mental status really relies on your clinical suspicion, which is going to hinge on your history, either given to you by the patient, family member, or EMS, and a good physical exam, which is going to be tough to do, and it may be limited by how acute the patient is. The big causes of nonfocal AMS are drug infections and metabolic derangements, so the labs are going to be based on that. Given that there's a possibility of drugs, you want to get a urine drug screen and blood alcohol. For infections, you're going to get a CBC, chest x-ray, and UA. Urosepsis is a possibility. Also, you can check for possible kidney damage. And then metabolic causes, finger stick blood glucose, ABGs, electrolytes, and osmolality. Metabolic acidosis is a common cause of AMS. You got to figure out whether it's an anion gap metabolic acidosis or not. If it's not, it's probably diarrhea or renal tubular acidosis. If it is, go down your MUDPILES mnemonic. And also bear in mind carbon monoxide poisoning is a possible cause of anion gap metabolic acidosis. So look at your history. This guy was found in a garage. That's suspicious, but there was no running car. And when you get the rest of your labs, it will help because you'll probably be able to identify a cause. Remember to treat the underlying cause. The patient's going to be admitted to the ICU and make appropriate consultations. In this case, it was nephrology, toxicology, and then psych for a likely inpatient admission after the patient is stabilized.